Let's put it over here. Thank you, Chairman, dear colleagues. I would like to thank my friend Dr. Gautam for this kind invitation. Everybody's hungry. I will shortly summarize this topic for you and have the questions. My topic is hysteroscopic correction of an incomplete uterine septum justified prior IVF. As we have published in 1995 from Baylor College of Medicine, we have been using office hysteroscopy since then, and we have published that screening office hysteroscopy should be done prior each IVF cycle to rule out any uterine. As we know, Mullerian anomalies are encountered with an incidence of 2 to 4% in fertile women and 3% in infertile population. When we have the recurrent implantation failure or losses, this can increase up to 18%. Septate uterus carry a risk of spontaneous abortion between 28% and 45% in the first trimester and 5% in the second trimester. Regardless of the mechanism playing a role, miscarriage, IUGR, presentation abnormalities, cervical incompetence, and ectopic pregnancies are also reported to be more prevalent in patients with septated uterus. However, there are conflicting results regarding the presence of a septum as an etiologic factor of fertility. We all know, according to the American Society for Reproductive Medicine, an incomplete uterine septum is classified as class 5 or an arcuate uterus as class 6. The American Fertility Society has stated because the arcuate uterus is externally unified, it could be classified as a form of partial septate uterus. So, what's the importance of arcuate uterus in IVF success or IVF results? There is a very good study, retrospective study coming out in 2010, Tomasevic et al., a retrospective match control study of 2,481 embryo transfer in conventional stimulated IVF ICSI cycles. The study group has 289 embryo transfers before and 538 embryo transfers following the hysteroscopic resection. Pregnancy rate after embryo transfer before hysteroscopic metroplasty were significantly lower, both in women with septate and subseptate and septate uterus, and in women with arcuate uterus compared with controls. If 2 or 3 embryos with at least one best quality embryo were transferred, the difference was 10% versus 45%, and 21 versus 35% respectively. Difference in terms of live birth rates even more evident, to 2% to 40%, to 3% to 30% after surgery. The differences were disappeared. Another study from the same group in 2009, this was a retrospective match control study, included 31 women who conceived following IVF or ICSI before hysteroscopic resection of large and small partial uterine septum, and 106 women who conceived following IVF ICSI after hysteroscopic resection of a large or small partial uterine septum. For each pregnancy in the study group, it was found two consecutive pregnant control women from the IVF ICSI registry. The abortion and pregnancy rate was the main outcomes. The abortion rate before hysteroscopic metroplasty was significantly higher, both in women with small partial septum with arcuate before resection and 24% in the normal controls. After the surgery, the abortion rate was comparable to the abortion rate in women with normal uterus, in both women with small partial and women with larger uterine septum. Similar to a large uterine septum, a small partial uterine septum is an important and hysteroscopic preventable risk factor for spontaneous abortions in pregnancies after IVF or ICSI. This brings the question of the importance of surgery in the arcuate uterus. And a study from Antalya in an IVF ICSI cycle, a prospective study, which was done a private institution, stated clearly that hysteroscopic surgery has increased the pregnancy and delivery rates following the surgery in women who are undergoing IVF and ICSI. Another study from Turkey, which done on arcuate uterus surgery following arcuate uteruses in 11-month period, the spontaneous pregnancy rate was 41%. So is the correction of arcuate uterus increase the pregnancy chance, or injury to the uterus increase the pregnancy chance? This needs to be studied. Another observation study included 900 single deliveries of 800 women respectively, and the perinatal outcomes were analyzed, and a small uterine septum was defined as having a length of 1.3 to 1.5 centimeters. When we look at the data, the preterm birth rate in group A was 40% before the surgery and 7% after the endoscopic resection. And the preterm birth rate in group B was 40% before and 8% after the endoscopic resection. This trial clearly shows that surgery improves the perinatal outcome of the patients with septum. And this is a very busy slide. It's showing all the studies done in arcuate and septate uterus and the results. And results are summarized before. I have summarized all those results in both IVF cycles and normal cycles. And when the literature on pregnancy rates and live birth rate and uterine septoplasty in women with septate uterus, when we summarize those studies, all the studies showed improved results for both perinatal outcomes and for both pregnancy rates. So in summary, this study or those studies I have summarized and the topic emphasize the role of hysteroscopic screening prior IVF is very important, the success rates and plus the perinatal outcomes of the pregnancy that we had in IVF and ICSI cycles. But the controversial area remains whether the incision of the arcuate septum improves the results or the injury of the endometrium, as you know, stated in some studies, improves the outcome. Thank you very much.